Okay, so hello everyone and welcome to our session tonight, Protexin Veterinary with Dr. Bonello, and we're presenting Periodontal Disease, the Silent Pain Epidemic, Part 2. So as I say, this is Part 2 of the session, so we also have had Part 1 as well. But don't worry if you've missed Part 1, just let us know and we can send you the recording to that one as well. I sent an email earlier today with the Zoom link. If you just reply to that one, I can send you Part 1 over as well, because you don't want to miss any of this. So just a little bit of housekeeping. If we have a little look at the session that we have here, we have a Q&A box down at the bottom of the screen. So if when we're going through, you have any questions that pop up, do pop them into that Q&A box. And at the end of the session, depending on how much time we have, we'll get some questions done, as much as we possibly can, which is great. So just a quick introduction of myself before we talk to Dr. Bonello. So I am Jill McMaster. I'm one of the vets here at Protexin. So Protexin has about 10 vets at the moment. So if you ever get in touch with us about a technical inquiry or anything like that, it's one of our team that you'll be speaking with. The benefit, of course, having vets in our team is we kind of know what's going on in the vet world. And this is why we've been very interested recently in dental disease and periodontal disease. So we really know how important it is, how a big part of veterinary nurses and support staff day it is to deal with dentistry. So as a result, as well as producing these kind of webinars, we have also launched a dental product at Protexin as well. So I don't know if you can see it just on the edge there. This is our Plaque Ease product. We have it in the UK and some other regions as well, and we're gradually going everywhere with it. Has been really popular. It's a pre and postbiotic dental powder. It's for dogs and cats. They seem to quite like the taste, which is good. And it helps control plaque. It's going to manage tartar buildup, reduce bad breath, and it also supports a healthy oral microbiome. So if you want any more information about the Plaque Ease, please do let your local territory manager or your local supplier know, and we can get you some more information. So following on from that, we'd like to introduce our speaker now. So really, really great to have Dr. Bonello back with us again. I know people absolutely loved the first session, so I'm sure this is going to be great as well. So Dr. Bonello graduated from the Faculty of Veterinary Medicine at the University of Turin. She also obtained a diploma of specialist in veterinary radiology and a PhD in veterinary internal medicine. After completing her alternate residency programme under the guidance of Professor Frank Verstraete, head of department at dentistry at the University of California, Davis, she became a diplomat of the European College of Veterinary Dentistry. So Dr. Bonello worked in private practice as a specialist in dentistry, consulting for both small animals and large animals. In 2016, she established the first dental practice for veterinarians in Italy. She has served as president of the European Veterinary Dental College and of the Italian Society of Small Animal Veterinarians. In 2022, Dr. Bonello relocated to Hong Kong to establish the Dentistry and Oral Surgery Department at City U Veterinary Medical Centre, and she is currently the head of the Dentistry and Oral Surgery Service at Harvest Veterinary Specialty and Emergency Hospital. So we're really, really great to have Dr. Bonello with us tonight. We can't think of anyone better to talk to us more about periodontal disease. So I'm going to pass over to Dr. Bonello. Thank you.
Thank you very much, Jill, for the kind introduction. And thank you to everybody that is online now and is taking the time to listen to this presentation. And we will the title is part 2, but it doesn't matter if you missed part 1, it's not consequential. What we will talk about tonight are the consequences of untreated periodontal disease. And not necessarily in this order, but we will talk about systemic dissemination of oral pathogens, about chronic inflammation, immune dysregulation, endothelial dysfunction, distant damage, and the more practical impacts like impact on glycemic control. And in the end, I will take a little bit of your time to talk about how to manage this chronic patient that cannot undergo surgical treatment. So we all know what odontogenic abscess is, okay? The symptoms are really descriptive of what is the cause. We have the dog or the cat with a swollen face, super painful, maybe not eating for a day or two, maybe feverish. At some point, the abscess burst, and what you look for is a broken tooth. And usually it is the fourth premolar, it could be the first molar, and this is what we think immediately when we see a pet walking in our waiting room, presenting with a swollen face. But tonight, we will talk about a different kind of abscess, okay? So what happens when a dog, for example, breaks a maxillary fourth premolar is that there is an inflammation around the apex of the roots. And this inflammation, if you do not extract the tooth, if you do not perform an endodontic treatment, is going to persist, and the pus that is created at the apex of the root is looking for an escape route. And as you can see here, this is a CBCT scan of a fractured maxillary fourth premolar. The abscess is on the mesial root, is also on the distal root. And here is a coronal view where you can see exactly where the palatal roots ends, so close to the nasal cavity, and the mesial root so close to the cortical bone of the maxilla. That's why usually when you see an abscess and swelling of the face, it is because there is an osteolytic process at this level and the pus is infiltrating the soft tissue in the maxilla. But as I was telling you, tonight we will not talk about these kind of lesions that are called class 2 endodontic periodontal lesion that are caused by a damage to the crown that provokes inflammation and then an infection of the pulp and consequently an abscess. We will talk about a different type of lesion that is always an endodontic periodontal lesion that starts at the level of the periodontal ligament. So it's called crown down because from the periodontal space, the infection is extended to the tip of the root. Everything starts with the formation of a pocket, with the disruption of the integrity of the gingival sulcus. So at this level, the accumulation of the plaque and the formation of the calculus and the persistence of this damage at that level causes the disruption of the epithelium, and the bacteria can proceed downward. And they find a highway there, okay? Because they travel along the periodontal ligament and they reach the apex of the root, and from there they infiltrate the pulp. It's not a process that takes 1 day or 2 days. It takes months. It can take years, depending on the response of the host. But I was telling you is a highway down, because the periodontal ligament, that is something that we actually do not see. It is a space. It is a space filled with, fibroblast and collagen fibers and stem cells and capillaries, and is connecting the cement that is revesting the roots to the bone. And to take a closer look, if you look up here, the Voltman canal, that are these little holes that are in the bone, in the cortical bone that is here, allowed the bacteria to travel from the periodontal ligament, not only toward the root apex and in the pulp, but also in the bone. So what happens is that this is not a classical inflammation, okay? What happens here is that there is no or little drainage, okay? In the bone, an infection is very difficult for the immune system to be healed because there is almost no drainage. So what happens is that the fight between the body and the bacteria create what is called a scorched earth effect. That means that destroys the tissue that are actually the battlefield. And we will talk about that. We will talk about the damages that in good will and in good faith the immune system does, trying to get rid of the tooth that has become a foreign body, because when the tooth becomes necrotic, it becomes a foreign body and it triggers a foreign body reaction. The body tried to get rid of the tooth, but to do so, as there is a lot of bone around the roots, it requires to destroy the alveolar bone. Sometimes it's easy. It happens usually with for example, the mandibular incisors. They become mobile and we think, oh, okay, they are mobile, it's normal. Or the owner comes in and says, oh, he lost the tooth. Then usually when a pet loses a tooth because of a periodontal disease, the damage is really, really more extensive than what you can see. So let's talk about that. Let's talk what happens when this battle goes on in the attempt of getting rid of the tooth. Sometimes it's not that easy, and there are complications that can be life-threatening. So let's start with the very common oronasal communication. Now, oronasal communication are a hole or a fistula or a draining tract that puts in communication the oral cavity with the nasal cavity. Usually it happens at the level of the canines and is more frequent in dogs than in cats. Why is that? So I tried to put images here to help you understand why this happens. So this is the maxilla, the coronal view of the maxilla, the axial view, sorry, of the maxilla of a dog with two huge oronasal communication or oronasal fistula. And this is the coronal view. So usually it happens because there is a pocket in the palate and this goes untreated and it gets deeper and deeper and it destroys the really thin septum of bone that is separating the root of the canine from the nasal cavity. There are symptoms, yes, sometimes, not always, usually nasal discharge or sneezing, but the owner rarely notices that, And actually, the best way of diagnosing an oronasal communication when the tooth is still in place is to use a probe and to insert the probe in the palatal side of the tooth, and you will go straight up in the nose. So why that is common in dog and usually doesn't happen in cats? Because the thickness of the bone that is separating the root of the canine from the nasal cavity in cats is higher. So it is rare that it can be perforated by the osteolysis at this level. Usually what happens is that you have resorption of the root. Cats are different, we all know that, and they are different when it comes to dentistry as well. So usually in the cat happens something different, okay? You have all this remodeling and resorption around the root that can become symptomatic with a gingival abscess that is called parolis or parolis. I don't know what's the accent in English. And probably you haven't seen these more frequently. You can see this bulging of the bone around the root of the canine. It's called feline alveolar osteitis and is typical of cats. That not necessarily means that the cat is experiencing some kind of pain or it is symptomatic. But when you take a radiograph, you look at the root, if there are signs of resorption, that's an indication for extraction. Oronasal communication are not only a canine problem, okay? Especially in dogs, it's really frequent to have oronasal communication where the premolars are infected, okay? So this is an example of an oronasal fistula from premolars in a dog. That can happen usually at the level of the first, second, third premolar, sometimes with the palatal root of the fourth maxillary premolar. But in that case, the infection is more confined to the maxillary recess. So it could be that it is not symptomatic for a very long time. When the periodontal disease, we are talking about severe periodontal disease, is affecting the molars in the dog, and then we will see in the cat, what happens is that you have a perforation of the alveolar bone, but the alveolar bone that is around the root of the first and the second molar in the dog is in communication with the periorbital space. So what happens, and this is an example, we have two holes that you can see here, and these are the consequences of an abscess of the roots of the second maxillary premolar. You can see it here as well. There is no bone around the second maxillary premolar, molar, sorry. And these are the roots of the first molar. You can see a widened periodontal space on the other side. And that means that what here is a huge abscess, on the other side is an abscess that is forming. That happens really often, you know. On one side, you have a worsened condition, that on the other side, that doesn't mean that you have to look at both sides and treat both the lesions. In the cat, I have to say, especially here in Hong Kong, I've seen many cases of infection of the periorbital tissues and sometimes of the eye. So this because, especially in brachycephalic cats, the roots of the fourth maxillary premolar are just below the eye. And sometimes the first signs of this infection are conjunctivitis. And it's not until the very end that you can see some swelling and understand that maybe the problem was not the eye, but was coming from the tissues around the eye. So this is an example of a case that was presented for conjunctivitis and has been treated for conjunctivitis for a month. At some point, there was this huge swelling of the face of the same side, and then the abscess burst. There was this fistula on the lip, on the skin of the muzzle, and was a case of a severe osteitis and osteomyelitis, and also osteonecrosis, because as I told you before, if there is no drainage, at some point the tissue die. But that depends also on the type of bacteria that you find. So my recommendation is when you find an abscess, especially now that there is a lot of discussion about the use of antibiotics and there are contradictory informations, it's really useful to take a swab and to submit for culture and sensitivity so that you know what you're dealing with. So what I find here usually are actinobacteria like Nocardia and Actinomyces and Pastorella, or mixed infections of coli and streptococci. Now, yeah, it's a list, and then you look at the report from the lab and you decide what antibiotic to use. But to dig a little bit more into it, you can discover that, actinobacteria are responsible, for example, for what we see happening when we do compost, for who has the possibility of doing it at home. And they release a massive amount of degrading enzymes, and they really destroy tissues. Nocardia is a very dangerous bacteria that is able to release toxins that are similar to the toxins that are also released from the Mycobacterium tuberculosis and are responsible for cachectic state in the patient. Pastorella can cross the blood-brain barrier. So it's rare, but you can have meningitis from teeth infection. That happens in people. And coli can create in immunodepressed animals hemolytic uremic syndromes. So it's a wild word that we really don't want to deal with, but as I said, take a swab, submit for culture, and is also teaching you a lot about what's happening in your area and the kind of bacteria you are dealing with, and also is a nice look into the antibiotic resistance that maybe you are dealing with. This is the cat, and this was the presentation. This was the opening in the skin, and this was what inside the mouth. Calculus, nothing really visible, but these are the images. This was a chronic infection in the bone with huge periosteal reaction, osteolysis, And this is the clinical presentation. This is necrotic bone and pus. So it was not a cancer, it was an infection from diseased teeth. This is what usually is more frequent in dogs. Dogs develop this kind of necrotizing fasciitis because the bacteria tend to travel along the soft tissues more than in the bone. Don't ask me why. I don't know why. I'm just telling you what I've seen in the ears. So necrotizing fasciitis in dogs caused by periodontal infection usually is a life-threatening condition. It is very, very rare to be able to cure this condition. It can be caused, it is classified in two types. Type 1 is a mixed infection. Usually these are always mixed infection of streptococci and enterobacteria. And then there is a type 2 that is more typical and similar to what happens to people, that is caused by group A streptococci, GAS, and that can lead to a toxic shock syndrome, especially in, of course, immunocompromised or old patients. So I don't want to scare you, but this is real. These things happen. I've seen many and many of them. And the aim of this lecture is, of course, yeah, how to deal with this condition, but also let's not allow this to happen, okay? But if it happens, you need to treat them surgically. You need to remove as much tissue as possible. And of course, you understand that one thing is to remove necrotic tissue from a leg. One thing is to remove necrotic tissue from the face. Sometimes is not possible. The medical therapy is called triple antibiotic regimen. Usually you associate 3 types of antibiotics, possibly wide spectrum, that are effective. So that's why you need your culture and sensitivity. And of course, all the supportive therapy that this patient may need. Sometimes they are not eating for days, they are dehydrated, or they can develop metabolic syndromes and really need hospitalization. Let's move on to other type of complication of severe periodontal disease. Small breed dogs, pathological fractures. And this is one of the most scary extractions when you have to deal with a first mandibular molar in these mandibles that are already really compromised by osteolysis. So this is an incidental finding. Actually, this fracture was kind of healed because the other side was still holding. The tooth fell off and somehow the fracture healed. But this is the one and only case that I've ever seen. Usually these fractures do not heal, and even if you treat them surgically, it is a very difficult and involved surgery. Why this happens? It happens, as I was telling you, in toy breeds, because the root of the first mandibular molar occupy a huge part of the mandible. And if an infection develops around these roots, of course, it affects the bone, it destroys the bone, and it destroys the cortical bone, and then maybe the dog sneezes and it breaks the mandible. But that is not the only thing that happens. You have a massive hemorrhage if that happens, okay? You can have a massive hemorrhage for a pathological fracture of the mandible. You can have a massive hemorrhage from the maxilla as well. Hemorrhage as a complication of periodontal disease happen when the vascular supply that is running in the infraorbital canal or in the mandibular canal is disrupted. And in this case, is disrupted by the infection. It can happen that the patient shows the symptoms, is bleeding from the mouth, and that at some point it stops. And it can stop for a few hours, it can stop for a few days. But then it happens again, because the abscesses have this acute chronic way of behaving. And so in the acute phase, you have the bleeding. So this is an example of a dog that was presented for bleeding in the oral cavity and in the nose. And it was from a huge infection of the maxillary fourth premolar. And this, by the way, it's a very recent one, was from the infection that was around the medial and distal root of the mandibular first molar. And as you can see in the actual CT scan image, it's invading the mandibular canal. There is also a perforation of the ventral cortex of the mandible. And so there was a swelling at that level. But the main concern was the hemorrhage, was the bleeding, okay? And it stops. You extract the tooth, you repair the damage, and it's done. It stops. Of course, it takes a little bit to heal, because not only soft tissue, but also the bone is involved, and the bone takes time to heal, but they heal. Sometimes this patient needs to be transfused. So if something like this happens, make sure before starting your surgery to get the blood type of your patient and be ready eventually for a transfusion. And this was the part about the local consequences. But then we have systemic complications, okay? And sometimes they happen and we don't even know that they happen. But let's say that when they happen because the systemic dissemination is happening via bacteremia, or metastatic inflammation, or metastatic injury. There's three different things. The end result, more or less, is always the same, is a damage at the distant organ or a systemic reaction of the body. We all know what the bacteremia is. We know that when we brush our teeth, if our gums bleed, then a bacteremia is happening. But in a healthy body, the bacteremia is overcome by the immune system in 15, maybe 20 minutes. But what about if the patient is not healthy? What about if the patient is immune compromised? Should we rely really on the body ability of overcoming the bacteremia, or should we prepare this patient for surgery? Because when we do scaling and polishing, when we do extraction, we, of course, create a bacteremia. And these bacteria, depending on who they are, let's say that there are some bad guys among them, can really create important damage in distant organs. What is a metastatic inflammation? It is a different type of reaction. A metastatic inflammation is the inflammatory response that is triggered by those bacteria that enter the bloodstream or the lymphatic system from a primary infection site. So what happens is that the immune system gets in contact with them and reacts. And reacts by, of course, all the way that the immune system reacts. We are not going through that now, but we have fever. Sometimes we have inappetence or anorexia. And we think that our patient maybe are, especially cats, they are not eating because they are painful, and you give pain medication and they are still not eating. And then maybe it is because they are dealing with a massive reaction that is not only in the oral cavity anymore. A metastatic injury is the direct damage that the toxins that are produced by these bacteria that enter the bloodstream can provoke. And this is a long list. But let's say that there are bacteria that have in their outer membrane these lipopolysaccharides that are able to activate not only an inflammatory reaction, but also the macrophages, the osteoclasts, and these are the gram-negative bacteria. And then there are many, many bacteria that can be gram-positive, like the streptococcus or the staphylococcus, that produce toxins that can create, as I was telling you before, systemic shock. And let's see, for example, there is a study that is a really thorough study about the damages created by Streptococcus canis that is so cold because was isolated for the first time in a dog, like there is a Streptococcus felis that was isolated for the first time in a cat, of course. So dogs and cats can be carriers, but when they are diseased and the mouth is a huge site of infection, of course, the concentration of these bacteria rises significantly. And what do? Oh, as I was telling you, they do a lot of damage because they have this ability not only to adhere to tissues, but also to invade tissue because they can block the immunoresponse. They are resistant to the phagocytosis, and they create lysis of the white cells of the leukocytes, and they inhibit the macrophages. And what happens is that in this study, they described few cases that were already recorded in the past. Some are from 1991. Arthritis, necrotizing fasciitis, myocarditis, and meningitis. Okay, so it is real. In people, mainly from dog bites, these are cases that were recorded, and they go from septicemic to cellulitis and septicemic presentations and endocarditis and periprosthetic joint infections. So it is real, as I was saying. And sometimes we think of many other causes because our patients are old, or they are nephropathic, or they have some other kind of endocrine disease, but it could be a combination of. So going through others, there is a study that tried to establish a correlation between the mitralic valve disease and the periodontal disease. So the score of the periodontal disease was 1 to 4, and they tried to relate these to the presence of mitralic valve disease. It didn't come up with a statistical significant correlation, this study, but for sure was showing that in the healthy group, there was less severe periodontal disease, and in the regurgitation group, there was more severe periodontal disease. The same happened with a couple of other studies that considered CKD. And what they saw that for sure there is a correlation, but there is also the possibility that the presence of CKD is triggering the worsening of the periodontal disease, or is creating periodontal disease from a healthy condition. And not being able to understand which one is the egg and which one is the chicken is a problem in human medicine as well, because we know that CKD or diabetes cause vasculitis and severe impairment of the peripheral circulation. And that, of course, can worsen any kind of inflammatory condition that is already present. So, for example, talking about diabetes, it is well known that managing the periodontal disease can enhance glycemic control in diabetic patient. And there is one study that is mostly case report that showed that by fixing the mouth, by treating the periodontal disease, it was possible to better manage the, to better control the glycemia in a dog. So in human medicine, treat the periodontal disease and get rid of all sources of infection, especially in the oral cavity, is part of the protocol to manage a diabetic patient. This is not in veterinary medicine, okay? Not yet. Because every time that there is a kind of consensus about protocols for CKD patient or diabetic patient, there is not a dentist there. And sometimes we step in when it's too late. So because of this kind of loop between the periodontal disease and condition like diabetes and CKD, in human medicine in 2017, the American Academy of Periodontology introduced an updated classification system for periodontal and, of course, in human peri-implant diseases that introduced, together with periodontitis as an inflammatory condition and necrotizing periodontal disease, the periodontitis as a manifestation of systemic diseases. So this is telling what? That if we see a patient with a moderate or severe periodontal disease, we should for sure focus on that and treat that, but we should also think, is all there, or there is something else that is a contributing factor to what I'm witnessing as a severe periodontal disease, as a condition in the oral cavity. Okay, so there is a branch of dentistry that is taking care of these patients. Okay, it's called palliative care dentistry. And in veterinary medicine, at least in my experience, it is the very last stage of life in this patient. So when you think that there is nothing else that you can do besides hoping or praying, it happens to me really often. You know, they send to me patients that cannot eat, that are in pain, and sometimes you cannot control the pain because it's not only pain coming from a tooth or from an abscess that can be controlled with antibiotics or pain medication, but it is already a neuropathic pain, and these patients cannot undergo a surgical treatment. So what do we do? This is what I would recommend: to treat these patients like they are a very complicated internal medicine case. So you start with a comprehensive medical and dental history, okay, to assess all the comorbidities, to, of course, identify all those medication, allergies that can or may interfere with the treatment that you are going to offer. And then what you need is also a previous dental treatment history, just to make sure that something was done, and if it was done, in the right way. And then you need to assess the patient for yourself, because you are going to prescribe medication. Some of these medication are going to probably interfere with the medication your patient is on, or are going to be a burden for an already impaired kidney condition or liver condition. Okay, so renal function test, liver function test. Don't be surprised if you will find levels of enzymes that are altered. Sometimes a chronic infection can do that, and sometimes by treating that chronic infection, you can improve the liver function as well, not the kidney function, unfortunately, but maybe the glycemic control, yes. Ask for help or refer if there are conditions that need to be stabilized, like, for example, heart conditions. Sometimes older patients have heart condition that required and that is recommended cardiology consult. And then there is a controversial interpretation of the C-reactive protein test. Sometimes, especially in this patient, is not really useful because it's going to be elevated. But anyway, if it can help, is one of the tests that you can add together with screening for infection diseases, if suspected. And then when it comes to the oral cavity, as I told you, swabs can help you address the infection with the right antibiotics. And also now many tests are available for detecting pathogens through PCR on the saliva. And then a very, very important part is the nutritional assessment. A body that is cachectic cannot fight, cannot react, okay? So taking care of the diet and prescribing supplements, and in the extreme cases, think about placing a feeding tube, is a very important part of the treatment of these patients. Of course, imaging would give you a better idea of what you are dealing with, but as we said, if they cannot be anesthetized, then CT scan or dental X-rays are out of questions, but you can try to do in a non-sedated patient oblique, lateral, or dorsoventral X-ray of the head, and that would allow you at least to detect macroscopic signs of disease. Together with the cardiologist and of course internal medicine, I usually consult with the anesthesiologist for pain medication, because I've learned so much by doing so. And really, sometimes what we think is an effective pain medication, it is not. And managing pain is the most important part of this treatment, because sometimes there is really not much you can do, but to give pain-free lifespan to this patient, I think is the greatest gift that you can give them. From a practical point of view, of course, these are surgical conditions. So if possible, surgery is the way to treat them, with teeth extraction, debridement. But if not possible, everything is reduced to antibiotics, together with everything we've discussed before about systemic conditions, treatment, antibiotics, analgesics, sometimes steroids, because, for example, when it comes to treat necrotizing fasciitis, steroids play a very important role, and topical remedies, okay, can or cannot contain antibacterial, antimicrobial agents, but combination of these and revisit, okay? Revisit, being available, and reconsider what you have done, and maybe try something different, adjust dosage. This is all I can tell you. There is not much more when you try to manage medically a surgical condition. And I really hope it can help. And this is the end of my presentation. So thank you very much for your attention.
Thank you so much, Dr. Bonello. That was, I've lost my sound. Thank you so much, Dr. Bonello. That was fantastic. Lots of really interesting points there. And we've already got some questions through. So if you're happy with that, we'll just get some questions started.
Yes, of course. Of
Perfect.
course.
So we've got a message in from Caroline, who looks like she's dealing with quite a difficult case here. So how do you deal with chronic bone infection with teeth that need extraction, an aggressive cat, which is on pain meds for arthritis, with chronic renal failure that is difficult to medicate? So quite a lot of elements in there.
So it looks like we were talking about something that not only me, but many, many other vets and nurses have dealt with. It's almost impossible to deal with osteitis and osteomyelitis or osteonecrosis without surgery. So the first thing that it comes to my mind is, please consider involving an anesthesiologist and try to because I mean, chronic kidney disease is not really an absolute no-go for anesthesia. So that it would be the way of trying to manage these case. Do you have a culture and sensitivity? Because that's the other thing, trying to see if there is any antibiotic that doesn't require, for example, 2 times a day administration that can work. And if not, it's a kind of death sentence. So what about hospitalization and maybe try a few days with an IV, or if not, what I've done in a few cases, if the owner was agreeing with that, is placing a feeding tube so that they can give the medication with the feeding tube.
That's perfect. Thank you very much. That's a great answer there. Have we got any more questions coming in just yet? So if you go to the bottom of the screen, there's a little Q&A box there, and you can type your questions. So please do see if you've got anything else. I've got one just popped in here. Excuse me. Do you consider that vets may be at risk of developing systemic problems by dealing with these patients, especially vaporizing infections during ultrasonic cleaning? Is a standard mask suitable for this kind of work?
That's a very good question. And I'm honestly always really concerned about myself, because when you deal with actinomyces or nocardia or, you know, these bacteria we've been talking about, yeah, it's a risk, of course. So what I recommend, and I take responsibility for what I'm saying, is usually you see these patients in a consult and you plan your surgery, okay? It's not that they just come in and you walk into the dental theater. So put them on antibiotics before, use a amoxiclav. Don't go deep into complicated choices because they could maybe become helpful later on, but treat these patients for a few days and then, yes, wear a mask, but wear also a shield, okay? So a mask and a shield is the best way of protecting yourself.
Perfect. Thank you, Dia. That was a great question, Peter. We've got another question here around the idea of lymphocytic plasmacytic stomatitis. So this patient has had a full mouth extraction. They're still intermittently swollen and intermittently uncomfortable. What are the next options that they have?
Oh, that's something that happens, isn't it? There is a percentage of these patients that are considered incurable. What I like to do when I deal with this kind of situation is try to know as much as possible about my patient. So if possible, I would like to have a biopsy, but a deep biopsy, not a biopsy of a piece of a gingiva, because that is not really going to tell me much. I would like to have imaging, so see if there are root remnants, if there are bone sequestrum. I'm talking about patient that, of course, walk in and I don't know anything about them. And of course, maybe you already have all these informations. I like a swab to see what kind of bacteria are but in my experience, the way of when it is possible, and sometimes it's possible, to drag these patients out of the hole of that chronic pain is to be super patient. So usually, if there are no contraindication, and I'm not going through all of them now, both local or systemic, these patients require a course of antibiotics, of course, but then they require a combination of steroids and gabapentin. And sometimes they need that for months. And before tapering down, you want to make sure that the symptoms are disappeared, and then you start tapering down the steroids, but you keep the gabapentin. And then you go on like that, step by step. And it can take 2 months, it can take 6 months, but usually it works.
Just put a little follow-up in here as well. What kind of dose of steroids?
Oh, you start with a non-immunosuppressive dose, so usually 1 milligram per kilogram of prednisolone.
Perfect. Well, that's really helpful. It's such a challenging condition, so great to have your ideas on that. Okay, two
This
more quick.
is
Oh, sorry.
public data. This is life experience.
Yeah. Thank you so much. So just got two more questions if we've got time for it. So quickly, this one is when measuring the periodontal pocket depth during dental assessment, do you measure from where the normal gun line should be or from the hyperplastic abnormally increased height of the gum line?
Okay, you don't need me to answer to these questions. So the depth of a periodontal pocket from academic definition is the distance between the enamel cement junction and the bottom of the pocket. So it doesn't matter if there is gingival reception or gingival enlargement or hypertrophy or hyperplastic gingiva. The pocket is the distance between, let's say, the neck of the tooth, the junction between the enamel and the cement, and the bottom of the pocket. Because
Perfect.
otherwise you don't have an objective measurement, because your pocket depends on where the gingiva is, and it should not be like that.
Thank you. No, that's perfect. So there's one last one here, and we'll just maybe finish off with this because I appreciate everyone's either getting back to work or finishing for the night. So Peter's just asking, do you consider pulsing doses of antibiotics in a very elderly patient is a valid method of controlling the condition when their general anaesthetic and surgery is just not an option?
Absolutely, yes. I would recommend to make sure to know which bacteria are the most aggressive, and so you can pick the right antibiotic. Because yes, it is true, we are dealing with many a form of antibiotic resistance, and you can be surprised that sometimes these bacteria come out resistant to almost everything.
Wow. Okay, thank you very much. That's really useful because I know that's a lot of cases that people end up seeing. So thank you very much, Dr. Bonello, tonight. That was absolutely fantastic. We all got a lot of really good stuff from that session. And thank you to everyone for joining us. As I said, we will have a recording of this. It'll be sent out next week. And I think just on everyone's behalf, thank you, Dr. Bonello, and it's been a real pleasure these last couple of sessions.
Thank you, Jill, and thank you, everybody, for taking the time of being here.
Thank you so
much. Have a nice afternoon or good night if you are in this part of the world.
Right. Goodbye for now, everybody. Take care.